This is Ethics Lesson 7. So, the chemical dependency counselor, whether they're from the healthcare profession or from this new profession only, can expect to face all the dilemmas that have been faced over the years by caregivers from other disciplines: threats, offers of bribes, and the temptation to maybe compromise your standards as part of human history. In every age and in every country, some agree and maybe some refuse. Cynics might even say everybody has a price. Perhaps, but I hope not. We all have different standards and feelings about where each of us has to draw that line if we're going to live comfortably with ourselves and sleep soundly at night. Some behavior is just so clearly unethical and unacceptable that it just requires no discussion. Other actions kind of lie in the gray areas where, maybe rationalization can make questionable practices seem all right if they're not examined too closely. And sometimes these are indeed all right when seen in full context. These questions are not the only ones that are important in thinking about our ethics as counselors. New ones arise and old ones change, and we're often still groping in, you know, uh, for many of those answers. But we can at least not be naive or unthinking and not be surprised or indignant when we see, maybe far too late, what was under our nose had we just been willing to look at it. So, when considering the ethics of a given situation, we would do well, to keep it simple, to think first of the patient and to ask, what is my professional ethical duty toward this patient? It may also help to ask, what do I want for myself or for someone important to me if I were in this person's place? Professional ethics has a deeper basis for right and wrong than just fear of being arrested or sued. Some legal actions are unethical, like segregation. It was legal, but was it necessarily ethical? And some ethical actions are illegal. But just because we're threatened with a lawsuit does not mean that we're wrong or we're going to lose. But even good people and their colleagues can be successfully sued if they leave themselves liable. So we need to reduce liability and reasonably reducing the risk of accidents and incompetent service, and by recording the remedies that we adopt so that evidence can be produced in court. Because remember, if you don't write it down, it didn't happen. Until the current liability crisis is resolved through tort reform or other legislation, we may let the fear of litigation determine our actions. Doctors often order unneeded and expensive tests and procedures for fear of being sued if they don't. Drugs and devices are being withdrawn from the market because it's impossible to guarantee there's going to be no side effects. Cases are multiplying where the same physician has been sued, sometimes successfully, for handling similar cases in exactly opposite ways. And these are ethical, competent practitioners who were wrong legally no matter which way they acted. It's impossible to avoid litigation altogether. Fear of litigation can easily distort our judgment and our sense of what is right or wrong. And there's going to be times when we must do what we believe is honest and ethical, no matter how it might appear in a court of law. If we carefully record what we've done and the thinking that supports our decision, the consequences are usually acceptable. Trouble is predictable when we appear to be either careless or malicious. Maybe we altered our records or we seem to make excuses. We need not all be exemplary lawbreakers like the saints and the prophets of major religions, but there will be times when legal justice conflicts with right and wrong. Then each of us has to choose a course of action known in advance to be a no win. And every code of ethics borrows from what other people have done in the past. And each code tries to reflect the particular profession's individual needs. And several codes have been developed for the addiction field. So, for example, by the American Society of Addiction Medicine, or ASAM, in 1992, and by the National Association of Alcoholism and Drug Abuse Counselors. The one offered here was initially borrowed from another source and then further developed in two different residential treatment centers, and then it was modified again after consideration of ASAM's code. It should not be regarded as finished, nor is it presented as a model, but it does reflect the efforts of a number of concerned people to, reach some sort of an agreement about how we as professionals in the addiction field can really conduct ourselves as we work together. It's going to provide a starting point. So, going over this would be a treatment center's code of ethics. So, as a member of the Great Place professional staff or a member of its board of directors, I will place the welfare of our patients and their families in matters affecting them above all other concerns. Number 2, to this end, I will deliver kind and humane treatment to all in my care, regardless of race, creed, reproductive status, sex, disability, age, or sexual orientation. Number 3, I will not deliberately do harm to a patient, either physically or psychologically. I will not verbally assault, ridicule, attempt to subjugate, or endanger a patient, nor will I allow other patients or staff to do so. Number 4, I will urge changes in the lives of patients only in their behalf and in the interest of promoting recovery from the illness we are charged to treat. I will not otherwise press them to adopt beliefs and behaviors that reflect my value system rather than their own. Number 5, I will remain aware of my own skills and limitations, since patients and former patients may perceive me as an authority and hence overvalue my opinions. I will attempt never to counsel or advise them on matters not within my area of expertise. I will be willing to recognize when it is in the best interest of my patients to release or to refer them to another program or an individual. Number 6, I will not engage in any activity that could be construed as exploitation of patients for personal gain, be it sexual, financial, or social. Number 7, I will not attempt to use my authority over a patient in a coercive manner to meet my own ends. I will not promote dependence on me, but help my patients to empower themselves. Number 8, I will not name or give information about a patient, a former patient, or family member except to other Great Place staff as required by treatment, or when specifically authorized by the patient. I understand and agree to defend both the spirit and the letter of Great Place policy on patients' rights and the Patient Bill of Rights, and to respect the rights and views of other professionals. Number 10, as a caring and a caregiving person, I understand that a therapeutic relationship does not end with a person's leaving Great Place. I will recognize the need to conduct any subsequent relationships with former patients with the same concern for their well-being that is acknowledged above. Sexual involvement with a patient is unethical. Sexual involvement with a former patient exploits emotions deriving from treatment and is therefore almost always unethical. Number 11, in my personal use of alcohol or other mood-altering drugs, I will serve as a responsible role model for patients, staff, and community. If I have been chemically dependent in the past, I will maintain total abstinence while employed at Great Place. Number 12, I will exhibit responsible concern for the well-being of my peers and the Great Place community by not ignoring manifestations of illness or unethical conduct in colleagues. Number 13, I will accept responsibility for my continuing education and professional development as part of my commitment to providing quality care for those who seek my help. For the next few slides, I'm going to read out the case study questions. However, you are going to answer these in the discussion board. So below this video, there is a link to the discussion board in the Google Classroom. There's the Google Classroom code right there next to the link. You should be able to find that. Your assignment is to answer each one of these questions in the discussion board and then respond to at least 2 of your classmates' responses to any of the questions. This will count toward your hours for this course, so I do expect for you to answer each one of the questions how you would respond to it. So this first question, you are a certified addiction counselor in private practice. A client comes for assessment of her son. You see a complex mother-child conflict and you warn her that the assessment may take 4 hours, including a test. She later complains to another professional that you have overcharged her. He agrees with her and says it should not have taken that long. How do you handle it? Did the other person act unethically? Treatment Center X offers to pay a fee directly to an intervention specialist. The interventionist refuses, saying that she considers this unethical, a conflict of interest. But if the treatment center wishes to reimburse the family for up to $400 of her fee, the family would be responsible for the balance. Who is right, the interventionist or the treatment center, and why? There's only one treatment center exclusively for women in the state, headed by a fully qualified and certified woman addiction counselor, also certified as a nurse addiction specialist. A major insurance company refuses to refer women to her because she is not a licensed psychologist or medical doctor. Is the insurance company's action ethical? An interventionist refers an overtly suicidal alcoholic and 3-time loser in standard alcoholism treatment programs to a 90-day residential center with excellent psychiatric staff specializing in dual diagnosis cases. The alcoholism treatment center to which the interventionist usually refers patients complained that he was violating their tacit agreement. Did the center act professionally in this case? An addicted patient's insurance coverage is running out. His withdrawal is over, but he complains of a depression, which is probably just typical of that stage. Your supervisor tells you to change the diagnosis to clinical depression so medical insurance will cover his continued stay in treatment. What should you do? I am a treatment center counselor and a member of AA. At an AA meeting in my community, I noticed that Geneva, a patient from my treatment center, is also in attendance. The patient talks in the meeting about having had a relapse the previous weekend. I realized she has not talked about her relapse in her outpatient treatment group, although patients are encouraged to do so in the interest of their own recovery processes. What should I do, if anything? Another patient tells you that in the AA group he attends, there's a man who mentioned committing a felony, embezzlement, for which he was never caught. He asks you if he has an obligation to the company that was embezzled to report this. Since there's no law of confidentiality that binds him as an AA member, what is your answer? Matilda M. is a patient on your treatment center caseload. She has a seizure disorder and has been told by her physician that she must take Dilaudid. It's an anticonvulsant to prevent further seizures. Her AA sponsor has told her that she has to change her sobriety date because you can't be sober and be on other drugs. How do you respond to Matilda? Your patient Mary introduced herself on a television program with the statement, "I'm Mary Brown and I'm an alcoholic." Now she worries that she's violated the AA tradition of anonymity. What do you say? Dagwood B., a client of yours, says he hates the meeting at 10th and Elm. What's your response? He also complains about all the God talk. Says he's an agnostic and does not buy any religion. Again, what do you say to him? You are the EAP counselor in a firm. An alcoholic employee whom you have been counseling, now in early sobriety, admits to you that he's been embezzling large sums of money from the firm. You're a trusted employee of the firm. Must you inform them? May you? What should you do? A recovering patient has made good progress, but it's clear she no longer needs your counseling. You want to terminate her, but your supervisor says that since her insurance is still covering her bills, you should continue treatment to help pay for some of the charity cases this agency has. What should you do? A young chemical dependency counselor trainee in an inpatient center is heard making a sexual remark to a female patient. The training supervisor fires him on the spot. He appeals to you, the administrator. Do you back the supervisor? How do you handle it? 2 years of continual sobriety is a condition for certification as a chemical dependency counselor in your state. A colleague, a recovered alcoholic with 5 years of sobriety, and a certified counselor working in the field relapses. You're the only one who knows, but not through any confidential communication from him nor anyone else. Is there an impaired counselor program in your state? If so, should you report this? If not, should you organize an intervention team? What should you do? What if this was just a brief episode that now apparently ended? You're an addiction counselor in an outpatient setting. A client you've been counseling, apparently with good progress, does not tell you that she's recently started seeing a clinical psychologist. You find out indirectly, but ethically. What do you do or say? Susie is an attractive woman whom you've counseled at your inpatient treatment program. You've been careful not to exploit the relationship in spite of the fact that she has exhibited transference of positive feelings towards you. She has now been out of treatment and sober for over a year. You meet at an AA meeting and she asks you to be her sponsor. Is this okay? Then she asks you to meet her for dinner before an AA meeting. Is this okay? What principles or guidelines are applicable here? A high-ranking member of the clergy tests positive for HIV. He has fathered several children and expects to continue doing so. He refuses to tell his wife about the test results. As a professional, what do you do? So far, the cleric state has no mandatory reporting law. How do you balance his right to privacy and confidentiality and his genuine fear of serious repercussions if the full story comes out, against his wife's right to help for herself and the children to come? You are a consultant to a firm whose president entrusts to you a company secret. She knows you usually share all such information with your partner, an old and trusted friend. This time she says you may not share it with your partner. When the news breaks, your partner accuses you of disloyalty. He insists you had a prior obligation to tell him, in spite of the president's wish, that you not share this particular bit of information. Did you act correctly, or is your partner right? A female counselor advised divorce for a couple, then married the husband. The wife sued her. Was the counselor ethical? An alcoholic patient recovering in your treatment center admits to sexually abusing and beating his child. State law requires that child abuse be reported to a state agency, even if known via a confidential relationship. Federal law prohibits identifying the patient as even being in your center. What should you do?